When an infant is born prematurely, their immature respiratory system lacks the structural integrity and surfactant required to independently sustain gas exchange. Percent and a P. These alarming numbers represent the gold standard of care. These targets are specific to managing and preventing bronchopulmonary dysplasia, or BPD. This syndrome is defined by a distinct clinical threshold: a premature infant, born at less than 32 weeks gestation, who requires supplemental oxygen for at least 28 days following birth. The severity of BPD is formally assessed using this logic timeline, measured exactly at 36 weeks post-conceptual age.
The classification is strictly determined by the exact amount of oxygen needed to maintain satisfactory oxygenation. If the infant requires only room air, the BPD is mild. If they require 30% oxygen or less, it is moderate. Anything greater than 30% supplemental oxygen classifies the BPD as severe. The clinical paradox of BPD is that the primary tools required to keep the premature infant alive, specifically positive pressure ventilation and high fractions of inspired oxygen, are the exact interventions that trigger the disease. Prolonged exposure to mechanical pressure and elevated oxygen initiates a complex pathological cascade. It causes intense airway inflammation, bronchial smooth muscle hypertrophy, and ultimately irreversible pulmonary fibrosis. Because the life support tools inherently destroy the developing lung tissue, clinicians must abandon the instinct to normalize blood gases. Treating BPD requires operating entirely outside conventional respiratory targets. The first rule of BPD management is establishing a strict boundary for oxygenation. The clinical target is maintaining the lowest supplemental oxygen needed to keep SpO2 between 88 and 92%. Pushing the SpO2 above 95% introduces immediate danger. High concentrations of oxygen generate reactive oxygen species, unstable molecules that aggressively attack and degrade the fragile premature lung tissue. This cross-section of a developing alveolus shows the precise cellular cost of oxygen toxicity. The introduction of a high oxygen environment drives interstitial edema and systematically erases the surrounding network of blood vessels, a process called capillary obliteration. Without an intact capillary bed to support gas exchange and tissue growth, lung development simply stops. This specific architectural failure is known as alveolar hypoplasia. There is a minor exception to this strict limitation. Once the infant reaches 33 weeks post-conceptual age, slightly higher SpO2 levels become clinically acceptable as the lung tissue matures. By strictly limiting inspired oxygen and accepting mild hypoxemia, we prevent the destruction of the infant's vascular bed. The second rule of BPD management addresses ventilation through a strategy called permissive hypercapnia. Clinicians deliberately allow the PaCO2 to rise, accepting levels as high as 60 to 65 torr. This severe elevation in carbon dioxide is permitted under one strict safety boundary: the patient's blood pH must remain stable and above 7.20. This split-screen visualization demonstrates the mechanical necessity behind allowing CO2 to rise. By utilizing strictly low tidal and minute volumes, we gently inflate the air sac, avoiding the forceful overdistension and shearing caused by high air volumes. Failing to prevent this physical shearing, known as volutrauma, causes the airway cartilage to collapse, a condition called bronchomalacia, and drives the rapid onset of pulmonary fibrosis. To execute this low-volume strategy, we follow a strict hierarchy of mechanical ventilation. If available, high-frequency oscillatory ventilation must be the initial mode to provide gas exchange with minimal pressure amplitudes. If HFOV is unavailable, conventional volume-controlled ventilation is the mandatory fallback. It must be chosen over pressure-controlled ventilation to prevent sudden, destructive pressure spikes inside the airway.
Regardless of the mode, the positive end expiration pressure, or PEEP, must be precisely optimized using the decremental method, carefully stepping down the pressure to find the exact minimum required to keep the alveoli open. The ultimate mechanical goal is to completely remove the shearing forces of invasive positive pressure ventilation by weaning the infant to nasal CPAP as early as possible. The consequences of mechanical lung injury are highly visible on standard imaging. This neonatal chest X-ray illustrates the hallmark signs: decreased overall lung volumes containing diffuse patches of collapsed atelectatic tissue sitting immediately adjacent to zones of severe hyperinflation. Accepting severe respiratory acidosis is a necessary trade-off to prevent the physical destruction of the infant's airway. The damage inflicted on the lungs does not remain isolated. Because of the interconnected hemodynamics of the chest, an echocardiogram is a mandatory diagnostic assessment for all BPD infants. This flow diagram maps the pathophysiological chain reaction. Pulmonary vasoconstriction, arterial hypertrophy, and the widespread capillary obliteration we discussed earlier create massive vascular resistance against the heart. Forcing blood against this extreme resistance causes the right ventricle to engorge and strain, leading directly to pulmonary hypertension and the development of cor pulmonale. Despite the presence of pulmonary hypertension, there is a strict therapeutic contraindication. Nitric oxide must never be recommended unless persistent pulmonary hypertension of the newborn is formally co-diagnosed. Instead of relying on late-stage rescue therapies, modern protocols focus on early preventative pharmacology. This begins with the prophylactic intubation surfactant extubation approach to stabilize the alveoli immediately after birth. Early administration of prophylactic caffeine follows, which significantly decreases the duration the infant requires positive pressure ventilation, alongside vitamin A to lower the overall BPD risk in extremely low birth weight infants. Fluid intake is heavily restricted. Diuresis is carefully driven using hydrochlorothiazide and spironolactone, while strictly avoiding Lasix. If the infant develops increased airway reactivity, a beta-2 bronchodilator such as albuterol is administered to alleviate episodic bronchospasms. Historically, corticosteroids were the mainstay treatment for BPD airway inflammation. Today, their routine use is completely abandoned due to the severe risk of inducing cerebral palsy. Only in the most extreme, life-threatening cases will neonatologists consider utilizing hydrocortisone. Modern pharmacology requires discipline. Traditional treatments are discarded for targeted agents that avoid catastrophic developmental side effects. Once the acute respiratory crisis is managed, the clinical focus shifts outward to the macroscopic, long-term stabilization of the neonate. Facilitating the gradual cellular repair of damaged lung tissue is highly metabolic work. To sustain this regeneration, BPD infants require a significantly higher baseline caloric intake than healthy newborns. Rebuilding the pulmonary architecture is slow. Complete weaning off supplemental oxygen is a gradual process that consistently takes weeks and often months to achieve. If the infant's respiratory failure is so severe that ventilator support is required or expected beyond 48 weeks post-conceptual age, a tracheotomy must be considered to ensure a secure, long-term airway. In most cases, the prolonged oxygen weaning protocol extends far beyond the NICU and into the home setting, which requires highly specialized delivery equipment. This is a medical oxygen flow meter, specifically calibrated for home care pediatric weaning. Safely titrating the infant's oxygen demands, a low-flow device capable of delivering absolute accuracy down to 0.25 liters per minute. Despite the severe trauma inflicted during those early, critical days of life, the long-term prognosis remains highly positive. With meticulously controlled support, most infants with BPD will gradually improve and recover over time. Managing bronchopulmonary dysplasia demands absolute clinical restraint. By utilizing permissive hypercapnia and targeted hypoxemia, we step back from aggressive intervention and buy the developing lungs the precise amount of time they need to heal themselves.